Other things that are occurring more in sort of the health arena that I'm excited about are care transition teams and patient-centered medical home. I told you my early career was as a discharge planner. Back then, 35 years ago, sometimes people went home and they were readmitted to the hospital. So it's been an ongoing sort of problem. And currently, through the Affordable Care Act, Medicare is saying, we're going to put in what's called a disincentive in the Medicare program. So if hospitals patients are readmitted within 30 days, there's going to be a penalty. And so hospitals are developing teams that are care transition teams. And so you've got case managers, discharge planners who are getting people ready, getting the plans and services set up. The care transition team is going to follow them for 45 to 60 days after discharge. They're going to be sure that people understand what needs to be done in terms of their health and well-being, medications, getting doctor's appointments set up, making sure people meet that, with the intent of reducing or absolutely eliminating readmissions for some people. So for me, I see that as exciting because, again, older adults want to stay home, but imagine if you've been in the hospital and you're getting home, you have a packet of discharge instructions and medications and appointments. And sometimes you need to talk to somebody. What did they say? What's the order here? And so these care transition teams are going to be really valuable. The medical center has been funded for a pilot study to do one, and they've hired a social worker, a nurse, and a pharmacist because of one of the huge issues for folks discharged from the hospital are medication compliance. Because on the one hand, they may come into the hospital with a certain raft of medications, and at discharge they have others. And managing that sort of stuff becomes really important. And so the pharmacist doesn't prescribe, but they provide a lot of patient education, and they can work closely with the physician. So from the hospital perspective, what you have is the hospital providing its services. There may be an intensivist or a hospitalist or a physician there in the hospital. And when the patient gets discharged, they have a primary care physician out in the community. So these transition teams are bridging that. And so, I mean, to me, I see that as sort of an exciting sort of space. Not all, but many of those patients will be older adults. And again, it goes back to my early experience. What helps people stay out of the hospital? What helps them stay at home? So I think we're really sort of bridging that particular piece in a really functional space. The other thing is patient-centered medical home. And it came out of actually a model for pediatrics in the 1960s. And it's an odd sort of phrase, but what it's saying is that the primary care physician is the medical home. That's where the medical care starts and stays essentially for patients. And not all kids have complex medical needs, but some kids do. And so this patient-centered medical home was a way to work from the primary care physician's office with other providers, hospitals, et cetera, as need be, to maintain the health and well-being of kids. Well, it's begun to take hold in what we call adult medical care in a variety of ways. And in the language in the legislation and what you see in terms of some credentialing around patient-centered medical home, they don't prescribe what staff absolutely must be hired, but they recognize there's a need for nursing care, a nurse in terms of education and coordination of care, the physician, of course, social work, pharmacy, behavioral health people, and there may be other kind of folks who might play a role. So a large physician practice may hire a team of folks, and so someone comes into the doctor's office and they may present with a particular problem, but they do some assessment and find out, well, there's other sort of issues going on here. They may be medical, they may be health or behavioral health, they may be psychosocial. And so somebody from this patient-centered medical team may provide services to prevent hospitalization, prevent the person becoming more ill, whatever. So again, it's much broader care. Physicians provide very, very good care, but if you think about what all they must do in the course of care, they're not able to necessarily address all the psychosocial issues, all the medication issues in terms of education about the medications and compliance with that. I mean, they're concerned and interested, but they're not in a position to provide all that education. Pharmacists are really good people to do that. From a behavioral health perspective, there may be issues that are identified, such as depression, that needs some intervention. And it might be that there's a behaviorist, a social worker, whatever, in the clinic, the doctor's clinic, who provides some psychosocial support, some counseling. One of the other things in reading the literature about patient-centered medical home, and this makes some sense to me when I read it, is that sometimes, the physician clearly identifies there's depression or some other mental health issue the older adult has, and they say, I really think you need some professional help, and I would encourage you to seek out psychiatric or mental health services. And the patient says, great, I'll do that. And they say, call the mental health center and it'll be okay. Well, so the patient calls the mental health center and say, great, we'll put you on our waiting list and we'll talk to you in 3 or 4 months. And so it may not go any further than that. Or they may get some other sort of runaround, or they may not understand how their insurance is going to work to pay for this because there's some particular limits. So with the patient-centered medical home, the social worker, behaviorist can work with folks to get them in and to monitor how that's going. Maybe they go to a particular practitioner and it's just not a good fit for that person, and so they quit, and yet they still need it. And what's interesting is, and this is probably true for all forms of care, et cetera, but in particular, sometimes people may seek out mental health services, and for some reason, they don't get along, or they don't like the person, they don't feel there's a good match there, and so they quit because they think, well, they're all the same. And so having somebody in the office help them identify the right kind of person, right kind of agency around behavioral health is real important. In addition, I think that in the physician's office rather, one of the things that will be a tremendous growth for social work and nursing, other mental health professionals, has to do with behavioral health interventions, smoking cessation, dietary pieces. There may be other sort of things around stress reduction, around caregiving, chronic disease, et cetera. So again, there's examples of evidence-based practice out there that folks can participate in to receive those services. So we live in an exciting time in terms of new services, new opportunities, and I think a lot of it has to do with viewing older adults in a very, very different way.